We can switch over from the naive GLP-1 receptor agonist to Tresiba at 10 units recommended as the initial dosage. When the patient is already on basal insulin, we can convert to 1:1 basal component to the premix. We can 1:1 we can convert. When the patient is on glargine or basal BID, we can reduce the dosage by 20 units because it is slightly better in terms of glycemic control. Now the patient themselves can have the insulin dosage done by this app which is available. So this patient, after starting insulin, they have a better glycemic control over a period of time and have control over the injection timings because of the timing variation that can happen. So this is my summary. The Ryzodec and Tresiba are designer insulin and then they are analog insulin. They have a greater HbA1c reduction and target achievement, lower risk of overall nocturnal hyperglycemia, lesser glycemic variability, and wider window of dose flexibility and improved quality of life in our patient. So with the newer generation of insulin, it improved the pharmacokinetic and dynamics, improved quality of life, low risk of hyperglycemia, less injection press, and also more predictable effect in terms of glycemic control. Thank you.
For practical information, I now call on the next speaker, Dr. Vidya Raju. She'll be talking on semaglutide 2.4 milligrams, stepping into the realms of high efficacy obesity medications. Over to Dr. Vidya.
A very good evening to everyone. It's an honor to be invited here to give a talk on semaglutide 2.4 milligram. I'm grateful to be in an era where we have options for managing obesity with anything apart from just lifestyle modification. So I'll be discussing the evidence we have for semaglutide in the management of obesity. This is my financial disclosure. This talk has been supported by Novo. I do not have any conflict of interest. Most of the time, our patients are losing a battle with weight management, and almost all the time, we judge our patients telling them, you're probably not eating the right kind of food, you're probably not exercising enough, and probably you should try harder. But obesity itself is not as simple as you eat less, you lose weight. It's much more complex. There are more than 100 different genetic polymorphisms that have been described that define how big a person will be. And apart from that, there are several centers in the brain, the hypothalamus, arcuate nucleus, and tractus solitarius, so many centers in the brain that control our appetite and satiety. But more than that, we have several hormones as well, not just the leptin and the ghrelin, but there are other hormones like agouti-related protein, neuropeptide Y. All these hormones and the neurohormonal pathways are all linked, and they send signal to the different parts of the brain, and that makes a person crave for food or to stop eating. So it's not as simple as telling the patient, go and change your lifestyle and you will lose weight. We need to be aware of the various pathophysiologies that involve obesity, and then try and tailor the treatment to our patients. So introducing Wegovy, that is a semaglutide 2.4. It's similar to the human GLP-1 analog. It works as a direct activation of the hypothalamus and also direct activation of the hindbrain. That is the nucleus tractus solitarius. So it works at parts of the brain where there is incomplete blood-brain barrier, and this molecule, what it does is that it increases the satiety, making your patient feel less hungry, but at the same time it does the hedonic regulation, reduces the food craving. So hedonic regulation is that where you feel like eating a pizza and then you end up eating a pizza, or you want to eat biryani and then you end up eating biryani. That is eating for pleasure. So that part of the brain that craves for certain kind of food, that part of the brain is again targeted by the GLP-1 receptor agonist. So it acts both at the homeostatic centers of the brain and also the hedonic centers of the brain. There are several trials looking into the semaglutide in weight management. We are aware of the pioneer trials that looked into the oral semaglutide, and also the sustained trials that looked into semaglutide 1 milligram in patients with diabetes. But what I'm going to be focusing on is the STEP trials that looked into management of patients with obesity without diabetes. So the patient profiles were almost similar in all these STEP 1 to select trials, is that patients were not diabetic, they were just obese with one or more comorbidities, and these patients were selected and randomized to receive placebo or semaglutide starting at a smaller dose of 0.25, and they were gradually titrated up to 2.4. More than 3,500 participants were from India. So that is something we should make note of, is that Indians also were part of this trial. So step 1 is the patients with overweight or obesity, and nearly 2,000 patients were enrolled in this trial. Male and female more than 18 years of age, but what is interesting is that nearly 76% of the people who were enrolled into the trial were women. Their BMI is more than 30 or more than 27 with more than one comorbidity. They should have had a stable body weight for more than 90 days, and their HbA1c should be less than 6.5. So they could be pre-diabetic but not diabetes, and if they develop diabetes during the trial, then they get treated with standard care. So they compared the effect of semaglutide 2.4 milligram with placebo, and the trial objective was look into the body weight, also the cardiovascular risk factors, the glucose metabolism and other factors related to body weight, and also they looked into the safety and tolerability of semaglutide 2.4 milligram versus placebo. So primary endpoint was to look at the percentage of weight loss and 5% responders, and also to look at the confirmatory secondary endpoints of what percentage had 10% or 15% weight loss. And also they looked into the weight circumference, the blood pressure drop, and also of the physical functioning quality of care questionnaires as well, based on the quality of care questionnaires. So what they found is that the placebo group at the end of 68 weeks, they lost only 2.4% of their weight, while the semaglutide group lost 16.9% at the end of 68 weeks. So the participants experienced significant weight loss with Wegovy compared to lifestyle intervention alone. So all these patients, we should remember, who were enrolled into the semaglutide trial continued to be on lifestyle intervention. Semaglutide does not work on its own. Most patients think that you go on this weight loss medication and then automatically you should lose weight. That is not the case. Lifestyle intervention should continue in parallel with the weight loss drug. So in that case, in clinical trials, there's nearly 17% reduction from week 0 to week 68 on the semaglutide group. And when we look into what percentage responded to weight loss, nearly 92% lost 5% weight. More than 10% lost 75% of weight. So 3/4 of our patients lost more than 10%, which is enough to reverse a lot of comorbidities. More than 50% lost more than 15%, and more than 1/3 lost more than 20% of weight. So that's a significant weight loss in a significant percentage of our patients. So this weight loss should be in combination with lifestyle intervention, which as defined by this clinical trial is 500 kilocalorie deficit per day and 150 hours of moderate intensity exercise per week. So what are the confirmatory secondary endpoints? The waist circumference decreased by at least 15 centimeter, systolic blood pressure by 7 and diastolic blood pressure by 3, the HbA1c reduced by 0.5%, and the physical functional score increased by 2.5, and the C-reactive protein, which is considered as a marker of inflammation, reduced by 58%. So there were other markers apart from just weight loss that they found beneficial in this trial. Step 4 is to look into the effect of maintained Wegovy versus treatment withdrawal. So what happens to these patients when the treatment is withdrawn after a certain period of time? So these patients had a run-in period of nearly 20 weeks where the dose was titrated from 0.25 milligram to 2.4 milligram, which is the maximum tolerated dose or the maximum available dose. And those patients who were able to tolerate 2.4 milligram continued to be on the trial, and they were compared with the placebo. The inclusion criteria was similar to what was there in the step 1 trial, and also the baseline characteristics. Nearly 79% of these individuals who were enrolled in the trial were women. Usually women are underrepresented in these kind of clinical trials, or they're nearly half the percentage of women, but in these trials the predominant population were women. Mean age of 46, mean body weight of 107 kilogram, and the BMI was much higher, 38 kilogram. Mean waist circumference was 115. So the endpoint at week 68 was to look at change in body weight from week 20, that is when they go on the maximum dose of semaglutide, and also to look at change in waist circumference, systolic blood pressure and physical functioning score from week 20. So what they found is that patients who did not adhere to the semaglutide, they did not adhere to the weight loss strategy, gained weight nearly 7% from week 20 to 68, but patients who were on semaglutide continued to lose weight, and they lost about 18.2%, and the percentage weight loss was similar to the step 1 trial. Step 5 is to look for long-term maintenance on Wegovy, and again the study inclusion criteria was same. Nearly 304 participants with overweight or obesity were enrolled in the trial, and again 78% were women, and the baseline characteristics were almost similar, and they looked for change in body weight and more than 5% reduction in body weight, and the secondary endpoints were to look for more than 10% or more than 50% reduction in body weight, and the trial was conducted for 111 weeks. So the participants experienced sustained weight loss over 2 years with Wegovy. So it's not something that is temporary. So you continue Wegovy, and as long as you continue semaglutide 2.4 milligram, the weight loss will persist, and the weight loss was about 16.7% reduction, and that's at the end of 104 weeks. And again, this is the trial that showed that Wegovy, this weight loss is achieved and it can be maintained at the end of 4 years. So to summarize step 1, 4 and 5, looking into the safety profile, the most common adverse effect or the side effect the patients complained was GI side effect of nausea and diarrhea, but these could be managed symptomatically. The most symptoms were described in the step 5 trial, but step 4 nearly 40% experiences symptoms compared to 26% in the placebo. Not a lot of serious adverse effects. There's nearly less than 3% of pancreatitis and gallstones cholelithiasis described, and adverse events leading to discontinuation was 7% in step 1 compared to 3.1% placebo. In step 4 it was only 2.4% compared to 2.2%, and in step 5 5.9% withdrawal adverse effects leading to discontinuation compared to 4.6%. SELECT is one of the largest cardiovascular outcome trials conducted in 41 countries, more than 800 sites and more than 17,000 participants, of which a small number from India participated in this cardiovascular outcome trial. And what they did was they selected patients who were obese with more than 27 of BMI, age over 45 years, and established cardiovascular disease, and there is no prior history of diabetes, but they could have pre-diabetes. The primary endpoint was to look for the first occurrence of composite endpoint consisting of CV death, non-fatal MI and non-fatal stroke.